Great. Good afternoon, everyone, and welcome to this month's American Institute of Dental Public Health ECHO session on innovations in rural oral health community care delivery. My name is Stacy Chazen, and I'm Director of Education and Leadership Programs for AIDPH, and it's my pleasure to be your host for today. Next slide, please. We want to start off by thanking our partners and supporters for this program: CareQuest Institute for Oral Health, the Oral Health Progress and Equity Network, UNLV, and the National Rural Health Association. So our agenda for today, we're going to go over some housekeeping items. We're going to remind you all about the ECHO model and give you a preview of what we'll be talking about. We're then going to hear from our partners at CareQuest Institute for Oral Health and their partner at Oral Health Ohio about a community care model that they are working with, which has some nice lessons for folks working in the rural oral health space. We'll have time for Q&A. We're then going to do a case discussion presentation that I'll be leading and go into breakout groups to do some think tank brainstorming, as we always do on these calls. Next slide, please. Some housekeeping items first. Today's call is being recorded, and the recording link will be posted on the AIDPH website and sent to all participants following the call. We ask that you please type your email address and organization name. If we could hop back to the previous slide. In the chat so that we can capture that you were here. You don't need to type your name because we see that. So just your email address and organization. All slides, resources, and the recording link, as I mentioned, will be posted on the AIDPH website. We remind you to avoid any personally identifiable information, health or otherwise, when you're speaking on today's call. And if you have any questions about Zoom during the call, please chat with my colleague, Grace Lynn. Next slide, please. So as a reminder, AIDPH's vision and mission are here. Our vision is an equity-oriented oral health workforce that is prepared to lead, and we work toward that by fostering professional excellence and advancing innovation in the education and practice of dental public health. Next slide. Our key programs and activities, which I invite you to learn more about on our website, are here. We have an annual colloquium that we'll be bringing back next year for the first time since COVID. We engage in national advocacy around a variety of issues. Our flagship program in the leadership and education space is our Dental Public Health Leadership Academy, for which applications are now open if you'd like to join our second cohort starting this fall. We engage in science and research. We lead an annual summer fellowship for which applications just closed. And we have a federal service immersion that's taking place this fall that I encourage you to learn more about. We'll share a link to the application in the chat. And this is an in-person trip to Washington, D.C., where you'll have the opportunity to visit federal agencies who work in the dental public health space. If you're considering a career in the federal realm, we strongly encourage you to take a look at that. Next slide, please. So the ECHO model, for those of you not familiar with it, is a telementoring model that's focused on building workforce capacity. We do didactic and case-based learning in a hub and spoke model that encourages you to take back what you learn on these calls to your organizations and communities to implement. And when we say all teach, all learn, that means we hope that you will speak up and share your own experiences and guidance while also learning from others on the call. And here is an overview of the ECHO model, which you can read more about on our website. Next slide, please. So this year's ECHO program is focused on innovations in rural oral health, which recognizes the distinct needs and opportunities for improving access to oral health among rural populations. Last year, our ECHO program focused on special topics in rural oral health. Folks had an opportunity to earn a certificate in that topic. You can still do that by watching the recordings from last year's session. And then this year, we're once again offering CEUs for these sessions and offering a certificate in innovations in rural oral health once you complete competency assessments for 8 of the 10 sessions that we'll be holding this year. Next slide, please. And you can read more about this on our website as well. Next slide. This month's topic, as we shared, is community care delivery. The rest of our topics are mapped out for the year. They appear on this slide, and we encourage you to take a look on our website and stay on alert for registration links for each of these sessions as they approach. Next slide. Putting up here are session norms. We encourage you to add your pronouns to your Zoom name. We ask that when you speak that you introduce yourself with your name, organization, and location. Please keep your video on, but keep yourself on mute until you're ready to speak. And we ask that you respect one another and engage in active conversation, but through a respectful lens. Next slide. And our presenters today declare that they have no financial arrangement or affiliation with an organization that's offering financial support or grant monies for this program today. So it's now my pleasure to introduce today's speakers. We are very happy to have with us Matt Vermillion and Julie Geiler. Matt is a senior program manager for health transformation at CareQuest Institute for Oral Health and has worked in dental public health for over 10 years. During this time, he's been responsible for developing oral health programs aimed at improving oral health education, access, and utilization. His mission is to find something that is big enough to matter, but small enough to win. And for the last 10 years, that something has been oral health. Julie is an integration consultant working with Oral Health Ohio to implement the Ohio More Care project. She has over 8 years experience working with organizations to implement integrated care in primary care sites, serving in roles as a grant administrator, project manager, and technical assistance associate. Prior to her role with Oral Health Ohio, Julie worked with integrating behavioral health and end-of-life care conversations in a large Midwest hospital system's primary care practices. I am going to turn it over to Matt and Julie. I'm going to, as they get started, I'm going to ask folks to pop questions into the chat as they come up for you, and then we'll make time at the end of their presentation either to go through the questions on the chat, or if folks want to come off mute and share those verbally, we welcome that as well. So take it away, Matt and Julie.
Thank you so much, Stacy. First and foremost, thank you all for being on here today. We really appreciate your desire and interest to learn more about our program and also participate in this ECHO format. It's really a tremendous approach to learning and sharing, and hopefully you guys learn a lot and you bring something back that we can bring back to our organizations as well. You can go to the next slide. So today we're going to describe More Care key performance indicators, describe More Care Ohio operations, and identify successes and challenges faced in More Care Ohio. And then at the end, as Stacy mentioned, we'll have some time for questions. Next slide. As you know, childhood caries is the most common preventable infectious disease among children in the U.S. And one of the easiest ways to prevent tooth decay is visiting a dentist. So what does this have to do with Ohio? Really simply, Ohio ranks 45th out of 50 states for annual child preventive visits. Secondly, our state partner, Oral Health Ohio, wanted to solve that problem by asking the question, what does value-based dentistry look like in Ohio? So based on this timeline, we wanted to give you kind of a rundown of how long it took us to get to the point that we are today. As you can tell, it takes time to do a project. And we had to do some fact finding, but to give you some context and background into how we got here, in January of 2019, Oral Health Ohio received funding from the Health Path Foundation to support community engagement initiatives aimed at improving the health of Ohioans. They chose to explore innovations in oral health care delivery and with a desire to close disparity gaps in Ohio. In 2021 and 2022, Oral Health Ohio convened over 40 stakeholders from diverse sectors to form a listening section or a session to explore ideas and concepts of value-based care and dentistry and identify opportunities for actionable value-based care implementation in private practice. Those stakeholders really wanted to explore value-based integration through care delivery, coordination with the focus on the pediatric population. So in February of 2021, the More Care pilot framework was introduced to those stakeholders, and then in July of 21, planning and implementation began. We were able to launch our learning community in November of 2022, and we currently have 8 participating clinics, 4 medical and 4 dental. And as you can tell by the timeline, we're expected to finish this project in 2024. Next slide, please. So let's talk a little bit more about what MoreCare is from a practical perspective. MoreCare focuses on removing silos between medical and dental practices through an interprofessional framework that includes both the integration and coordination of care. Now, I do want to note that integration refers to primary care's ability to manage oral health risks, apply preventive strategies, while coordinated care refers to communication between providers to improve how a patient navigates their unique health needs. Now, this diagram, as you can see on the left-hand side, we have the medical components. On the right, we have dental. But right there in the middle, in the reddish orange color, you have cooperative tasks. At the end of the day, these are the tasks that are uniquely shared by both our medical and dental teams. And the goal of those tasks is to create a coordinated care with the bidirectional referral system, initiating, developing, and improving interprofessional communication, and creating shared outcomes through collaborative, interactive practices. So really what we want to do here is we want to get the dental offices and medical offices to speak. As you know, the EMRs and EDRs don't really do that. So we're really trying to create a partnership where they see each other in a very positive lens, but they also understand the challenges that each other face. Now, with this at the bottom in the greenish teal color, we've also introduced the value-based alternate pay model, which we will talk about a little bit later. But the plan there is to incentivize program participants by financially providing incentives for data submission or pay for reporting, and performance measures that we will call pay for performance. Next slide. This kind of gets a little bit more into how MoreCare kind of works as a framework. The key components are really tied around interprofessional oral health networks. If you notice that there are 5 here, and this drives the medical dental integration by partnering, allows us to partner with state partners to build and strengthen local interprofessional oral health networks, primarily through integration and coordination of oral health within primary care. And that's kind of the key there. This all starts within primary care. Now, our framework is tailorable for each state's needs with regard to our framework and curriculum, but the ultimate goal is to improve the patient's oral and overall health outcomes. And in general, these categories consist of shared responsibility of oral systemic health, which is basically the understanding that oral health outcomes are not just the responsibility of a dentist. It requires joint ownership from primary care, case management, and behavioral health. It also requires the establishment of a referral network. And the importance here is creating a network of providers that really have the capacity and willingness to see patients who are in need of definitive care. Then we have transitioning care models, which speaks to transitioning to a prevention-first approach and the de-siloing of the multitudes of care. Environment of improvement. I love the phrase, if at first you don't succeed, try again. At the heart of this pillar, that's exactly what we're trying to do. For success, a clinic must be willing to try new approaches and apply a quality improvement lens so that they can test their changes and really learn and retest based on those outcomes. And then lastly, as everyone knows, as we move into a more of a digital space, health information technology, or HIT, is extremely critical for de-siloing medical dental practices. But with that being said, we also know there's a lot of challenges and barriers to that. So what we do ask our partners to do is to be creative in identifying ways to leverage their EMRs to make new processes easier. Some examples might include adding templates to their visit workflow, or even adding flags for reminders for the different providers. Next slide. Our key performance indicators as part of this project include those listed on these bullets here. I did highlight 3 oral health risk assessments conducted closed loop referrals, and self-management goals. If you were kind of flip back to those cooperative tasks I mentioned earlier, it kind of follows the same color pattern here. And the fact that I really wanted to highlight where our medical and dental partners come together to really enhance the patient experience and help them navigate their journey as they try to improve their health through oral health. Oral health risk assessments. Our goal is to educate medical providers on how to do risk assessments, apply fluoride varnish, as well as making a warm handoff to their dental partners. On the flip side, we are asking our dental partners to try to encourage that dental visit sooner than later, follow up with their medical partners on treatment plan and that coordination of care piece. So we won't jump into a lot of details here. I just wanted to highlight at least 3 of these key performance indicators so that you have a better idea of how we inform our clinics. Next slide. I like this graphic because it really gives you an idea of kind of where we are now versus where we've been. So More Care has been a program since 2015. Now, we did have a hiatus in 2020 due to COVID-19, but I think that's par for the course for most public health groups. But over the years, as we've operated in 5 different states, we've learned a lot, but we've also learned that some things don't translate state to state. So one of our goals with More Care is to constantly be in a state of quality improvement ourselves. So we've made quite a few enhancements, and I'll talk about the major enhancement we made for Ohio, which was the introduction of the alternative pay model, which this is the first More Care project that we've been able to implement this. Next slide, please. So as you can see from this slide, we have the pay for reporting as well as pay for performance. At the end of the day, the pay for reporting is kind of an easy way to set expectations for clinics on why metrics and data is important for a clinic at improving health outcomes. So as you can see here, we have completeness of reported required data, completeness of reported demographic data, and then quality of reported data. Basically, what this is saying is, did they send us the stuff that we needed in a usable way that can help us tell a story for them to use in their clinic to improve patient outcomes? It's not in my slide deck. Actually, this month we just received our last clinic's data, but I am happy to report to you guys that 100% of our clinics actually achieved all 3 of those metrics at 100%. So we're really proud of that. So really exciting times there. Additionally, pay for performance really kind of gets into the nitty gritty of what we're asking our clinicians to do from an outcomes perspective. Now, if you look at this, we have 3 different buckets. We have more of a purple bucket that focuses on the medical practices. We have the middle bucket, which is in green, that's focused on dental practices. But we also have a blue bucket, which identifies non-incentivized metrics that we do collect for both dental and medical clinics. And that's really just to help provide some additional insight into their patient population. Now, I'm not going to get into the details here. I just wanted to highlight this is how we collect information for this project and also break down the different incentive avenues for our alternative pay model. And with that being said, we can jump to the next slide. And Julie, I'll hand that over to you.
Hi, I am Julie Geiler. I'm the state facilitator in Ohio for the More Care project. And this is a little graphic of where our practices are located. We have 4 medical dental teams. 1 is in Toledo, which is at the top of the graph, and the other 3 are in rural Southeast Ohio. 2 of the pediatric practices are affiliated with larger hospital systems, and 2 are smaller private practices. We have 1 dental practice that's part of the dental service organization, and there are 2 private dental practices, one of which has 2 locations and serves 2 different primary care sites. It's a 24-month program. 9 months is active earning community, that should say learning community, I'm not sure where my L went, and a 16-month data reporting or sustained change engagement. So we work with the practices for 9 months, and then after that, they report data over that period of time, and then we'll continue to touch base with them. So next slide, please. Our learning community, again, it's a 9-month medical and dental learning community. CareQuest has developed a learning management system, which the clinics use monthly. Initially, a lot of the modules were Smiles for Life, so they were about clinical improvement and understanding how oral health is part of whole health management. There are additional modules developed by CareQuest for quality improvement that talk about a PDSA cycle, care coordination, those types of things. There is a monthly action call, which I lead with the medical dental teams, where we come together once a month. We go over what was the learning for the month, and then talk about any successes they've had, any challenges they've had. One thing that's been really exciting is how generous our practices have been with each other to share information, share data about coding. And when one practice has a challenge, someone will step up and help with what they're doing or how they've managed that. I do coaching calls with specific practices to talk about what's going on. We go over some really great reports that CareQuest has developed on the data. And then we've been able to provide the sites with resources. Oral Health Ohio was able to provide them with oral hygiene kits that were given free to the practices that they could then give out to their patients. They arranged for varnish application training. And then we've developed some patient handouts for practices with QR codes so that they can give those out to their patients. Next slide, please. So some of our stories, and we're just getting started, so we've got some really great stories. Some of the challenges that we had with recruitment, we had hoped to recruit 5 sites versus 4 sites. Oral Health Ohio, building on their relationships with stakeholders around the state, were really integral in helping us develop the sites that we did. We started with a small number of target counties and then had to increase that to be able to get to 4 sites. Successes in recruitment, we've got some really committed partnerships, and then those close ties that are developing between some of the practices has really been great. Resources, challenges, some of our dental practices are a good half hour, and I mean a good half hour away from the medical practice, and they're not easy drives, so that's difficult for patients to get to sometimes. Most of our practices have really limited staff for this effort. They have few dedicated data managers or minimal staffing. One of our primary care practices, it's the pediatrician. She's got an office manager and a billing manager. Every time we've spoken with her, she's taking texts and calls from her patients on her personal cell phone. So they don't have a lot of staff to do this. Incompatible and difficult EHR systems, and then the practices are just overwhelmed. If you think about all the flu season and the COVID, these docs have been, seeing a lot of patients for illness, so it's hard to dedicate that extra time to learning communities and learnings that they have to do for the project. Successes, CareQuest was able to come up with a system to help one of our dental practices who couldn't easily export that data. So they got an application to be able to help with that exporting. Providers and systems that have had previous QI initiatives, that has been helpful, and they're onboarding much quicker. One of our pediatricians wrote his own software, so he is able to edit that to put in data fields that he needs. Definitely not typical. And then oral workflows have been developed in pediatric sites. So they've been able to institute these as a typical way of doing business now. Next slide, back to Matt.
Yeah, so thank you, Julie, for that. I always like hearing about what the clinics have been doing. And it's so exciting to see kind of where the project's been. At the end of this presentation, we did want to kind of show you guys like the bigger picture. So value transformation resolves from equitable, accessible, and integrated care. And the key principle of our project has really been transforming care delivery by focusing on providing the right care to the right people for the best outcomes. So at the conclusion of our project in 2024, we're really hoping that it will inform and educate policy and decision makers in Ohio on the value of a medical dental integration and alternative payment models to truly improve patient outcomes. And at the end of the day, it requires collaboration. It requires joint effort from a lot of different people. And we're just really excited to be able to share this presentation with you guys. In fact, we may even be able to drop in hot off the presses blog post featuring 2 of our providers from this project. So if we can't do it on this call, Stacy will definitely route that to you to share with those that participated in the call. Next slide is just open for questions. So.
Thank you, Matt and Julie. And if you're asking me if it's okay to share it, yes. If the question is you don't have it ready yet, then we'll send it out after, but please feel free to pop it in the chat if it's ready to be shared.
Yeah, I can't multitask. You'd think after 2 years of living in a virtual world, you could do more than one thing. But if I can make that happen before this call is over, I'll drop it in. If not, we can get it emailed to everyone.
Okay. Or feel free to email it to me and we can do that for you. Thank you very much.
Thank you.
So folks, feel free to come off of mute or raise your virtual hand or pop a question in the chat. And while we're waiting for someone to do that, I will say one question that occurred to me is I'm curious about what the provider recruitment process was like. What were the selling points for the primary care providers as well as the dental providers for setting up that referral network? What was the response that you got, and what seemed to work well for you?
Julie, you've been at the project a little bit longer. I'll let you take a stab and then I can maybe provide some support.
The recruitment process was both difficult and easy depending on the site. We had some providers that wanted to be part of the program that we just couldn't negotiate around some particular things about their practices. Other sites were very engaged. It's things they've been wanting. I'm speaking medical side, things they've been wanting to do. So it was an easy sell to them. It was having the additional dollars there to help with the data set up in the beginning to help them get started was an easy sell. We had, again, hoped to have 5 practices and we're not able to do that. It took a lot longer than we thought it was going to take to recruit 5 practices. So we ended up with 4. So start early. That would be a tip. Start early.
Matt, do you want to add anything?
I think Julie summarized it up really nicely. I think Ohio has, from a participation with Medicaid, I think that's also a challenge that you would want to identify early on as you're recruiting is your provider mix within the Medicaid population. I think that can also contribute to the recruitment challenges that you may face in a state.
And let me just say, Oral Health Ohio has a statewide reach and has developed relationships with Medicaid, with rural health, with all sorts of stakeholders. And so that was key to us being able to reach out to recruit sites and let them know about the project and the opportunity.
Great. Christine asked, why do the patient handouts have QR codes?
Interesting question. From, I think it was Matt's experience, patients want to be able to use their smartphones to be able to pull the information up. They don't want a handout. It's expensive for practices to print the handouts that then go into the garbage can. So it's just the way of the world. Everything is remote.
Yeah,
Cheaper.
no, I was going to echo Julie's comments. At the end of the day, members provide or prefer to be able to access things on their own. And sometimes as they're leaving a clinic, they get asked 400 questions about next appointments, prescriptions, things of that nature. So it's very easy to scan a QR code, leave, and then read it at your leisure.
Great. Meredith added in the chat, QR codes have been really helpful if everyone has a smartphone. We need to provide paper copies for those that don't have the tech yet. Any other questions? We have such a great turnout today. I need to scan 2 pages worth of faces and names here, which is
Stacy, one just came in, a question, it
oh,
looks like.
thank you.
Sure.
In Pennsylvania, pediatricians/PCPs can apply topical fluoride varnish to children under age 5 or 6, depending on whether medical assistance or commercial insurance. That training information is provided through Healthy Teeth, Healthy Children. Our dental care manager team provides this training to PCP and pediatrician offices. So this is just offering a way that another state does it.
And in Ohio, medical assistants are able to apply fluoride varnish in addition to the medical providers.
Great. Any other questions? Okay, Matt and Julie, thank you so much. And
Yes.
stick around, don't go anywhere, because I think we're very familiar with the case that we're going to be talking about. So we'd love to have your voices here, particularly Matt, as we move forward. So we're now going to move into the case presentation part of today's call, and we're going to do it a little differently this month. And Christine, if you could take us to the next slide, please. We are going to talk about a new initiative that AIDPH and CareQuest Institute for Oral Health are going to be launching, for which we'd like to get some input from you. So starting next month, we are going to be hosting a Veteran Oral Health Action Collaborative. And this new initiative, supported by CareQuest Institute, reflects the fact that veterans in the US face disparate access to oral health care. I was really surprised to learn when I started working in the veteran oral health space that only 15% of veterans are currently eligible for dental care through the VHA. And as a result, nearly 8 million of them report that their oral health is not good. And what we're finding is that there are pockets of innovation of organizations and states and communities that are testing some different approaches, but there is no central place where they are receiving support, guidance, a forum to talk through challenges, nor is there a comparable mechanism for them to be sharing potentially best practices, promising practices, sharing resources that may have worked for them, approaches that may have worked for them, so that when we're finding something that's working in terms of expanding access to care when coverage is not available, or if an organization is engaged in advocacy efforts around veteran oral health to try to expand that benefit, there is no one place that they can convene to share what their experiences are, particularly their successes. And so this Veteran Oral Health Action Collaborative, or VOHAC, because everything needs to have an acronym, is providing a space for that. Next slide, please. So as we're launching this, the program is an 8-month intensive program. We'll be offering monthly calls, or monthly intensives as we're calling them, that are going to feature interprofessional presenters that build on concepts of care integration and value-based designs to advance solutions for veteran oral health issues. The program has been designed for clinical professionals, community representatives, advocates, any other stakeholders who are working to advance coverage, access, and quality of oral health care for veterans, either at the community, state, or national level, and are seeking to find solutions, to learn from others, to do some collective troubleshooting and problem solving. This will be a space for them. Next slide, please. So our asks of you, as we are finalizing our topics, finalizing the content of our topics, and wanting to tap into work that's already going on in this space, as well as learn about how we can best support you as stakeholders, is we're asking a few questions. We'd like to understand to what extent your organization has explored the oral health of veterans in your communities, and what needs or other findings arose from that effort. What work your organization has done in the veteran oral health space, and what information, technical assistance, or other guidance would your organization need to begin or to expand its work in that space. So as we always do on these calls, we're gonna can take us back one, Christine. We're going to go into breakout rooms shortly. We're going to paste these questions in the chat. 2/3 of you are going to be sent to breakout rooms. The other third are going to stay in the main room with Grace and me, and that'll be our room. And we're going to give you about 15 minutes to talk through these questions. Your room will have someone on our staff or faculty who will facilitate, as well as someone who will serve as scribe to capture notes. And we'll be recording in all of the rooms so that we make sure we don't miss anything. So that being said, thank you, Grace, for posting those in the chat. Please, we hope that you will keep your camera on or turn your camera on. We find that the conversations in these breakout rooms during the case section of these calls are so much more engaging when your camera's on, and we want to have an opportunity to hear from everybody. So in a moment, I'm going to ask Grace to open up the breakout rooms, and you will be in those rooms until 3:53 Eastern time, and then we will bring you back. And we're going to ask folks to share out when they come back to the main room. So we'll see you soon. And Christine, you could stop sharing now if you. Welcome back, everyone. I hope you had good conversations. I wonder if anyone would like to share out about what came up in their room. If there's something your organization is doing that you'd like to share, that you offered up to your group, or some particular resource or area of assistance in which you'd like help that you'd like to share.
Stacy, this is Christina. I helped facilitate the second room, and I think we had some wonderful discussion. There were some topics on before a veteran has to be, or a soldier has to be deployed, they have to have a full workup, right, to make sure they're healthy. We thought perhaps there could be some type of model that upon rejoining society after their wonderful service, could there be another opportunity for them to have additional care so that once they go get I guess, go back into their workforce, back into their life, maybe that quality of care is there, because we all acknowledge that accessing dental care for veterans, especially those without those requirements, the income requirements to get care within the VA, might be more difficult. So we thought maybe there was a way that there could be some type of model, prior to them no longer serving, whereby they could still get this dental treatment before they're back into society. And then we thought perhaps working with an integrated care model to incorporate more of the preventive dentistry in that, to make sure that we're not just addressing the chief complaint, pain, infection, swelling, the more dire need where they might lose their tooth and they're, not able to function in some ways. Could we somehow instill some type of preventive model, as well as incorporating more specialists within our training, either in an academic setting or other setting, where we bring in medicine, mental health, and other services. So we talk a lot about academia and how we can train our future dentists or workforce, but also just in general, looking at the model of how can we incorporate more prevention and integrated medicine or health or mental health within this model of care.
Great, thanks for sharing that, Christina.
And I'd like to share from the same room that one thing that I thought stood out to me about information or guidance that may be needed in this particular space that could be provided through this new project was really how to get buy-in from leadership and providers on engaging this population, and really training especially providers on how to care for veterans most appropriately. We had a good discussion about trauma-informed care, so those types of resources on how to really get the buy-in from the top down would be really helpful.
That's great. Thank you, Caroline. Anyone else before we wrap up?
I'll share from room 1. So we had a good discussion. It didn't seem like a lot of the organizations were doing anything with veterans yet. So a lot of potential there, a lot of need for research and discovery into the needs of veterans in their area. So AIDPH has our state profiles, and I will make sure that those go out in an email to everyone registered. That's some really pertinent research that we have that might help inform those programs. And then, yeah, just a lot of questions about education to make sure that we are treating people in a culturally sensitive way, that they might have PTSD or different issues that would be barriers to coming to those appointments. So a lot to learn for everyone.
That's great. Thank you. Okay. Well, Christine, would you mind taking us back to the slides, and we're going to wrap up with some next steps. Thank you all for sharing today and giving us some insights that will help us to make that program the best it can be and most valuable to all of you.
You don't want me to share my that screen. Hold on. Is that one better? Yes.
Yes.
Can you see that? Okay.
Yes. All right. And if you'll take us to the next slide, please. Okay, so next steps. CEUs are available for today's session, and the survey link is going to show up in your browser right after today's call. Recordings and resources will be available on the AIDPH website in the coming days, and we'll also be pulling together a summary of the recommendations that came out of the discussion and brainstorm just now. We invite you to visit our website if you'd like to share your organizational, community, or clinical challenge related to rural oral health to present during this think tank session of the calls. And we invite you to join us for our next ECHO session on June 15th at 3 p.m. Eastern, when we're going to focus on innovations in partner and stakeholder collaboration. And that is what we have for you today. So thank you, everyone. Thank you again to Matt and Julie. Quick question before we lose everyone. Matt and Julie, how can folks find out if there is a More Care program in their state? How can they find out about it if they want to get involved?
It's a really, really good question. Right now, the only More Care program we have going on is in Ohio. But Stacey, if someone is interested in potentially doing something in their state, they could email me directly, and we can put that into our intake form as we evaluate future enhancements.
Okay, thanks, Matt. We'll include, if it's okay with you, can we include your email address in the follow-up? Okay, we will do that. Thank you so much.
Thank you,
everyone. Have a great day. Bye-bye.
Bye.